1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, usually when we talk about a medical diagnosis, there's this expectation of like clinical precision. It feels like engineering.
Right. Very binary.
Exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points at the film and says, well, there it is. Broken or not broken. It's clean.
We definitely crave that visibility, you know?
Yeah.
You want to categorize a problem neatly so we can just apply a neat solution and move on.
But then you step into the world of intensive care, specifically cardiovascular hemodynamics, and suddenly that x-ray machine feels completely inadequate. We're looking at a diagnostic and physiologic landscape that is just incredibly murky. I mean, it changes second by second.
It really does. And that's why surviving the ICU or helping a patient survive it isn't about just memorizing basic anatomy. It's about learning to think critically when the physiology is failing right in front of you.
Which brings us to our mission today. We are taking a massive stack of medical texts on the cardiovascular system, and we are ruthlessly applying the 80-20 rule to it. We are stripping away all the fluff and focusing strictly on the highest yield clinical pearls, the stuff that drives bedside decision-making and actually saves lives.
Because when you hear an alarm going off in a critical care unit, you can't just hear noise. You have to literally visualize the failing physiology. You have to identify the immediate threat and know exactly what your priority nursing action must be.
So we are going to treat this deep dive like a high-stakes ICU shift. We'll look at the heart as a mechanical engine, hook up the invasive lines to monitor it, assess a deteriorating patient as it happens, and finally run them down at the cath lab.
Sounds like a busy shift.
It's going to be wild.
Right.
So let's unpack this engine. The entire existence of this engine, the reason it beats, 100,000 times a day, boils down to one fundamental equation. Cardiac output equals heart rate times stroke volume.
That is the foundation of everything we do in cardiovascular critical care. Normal cardiac output for an adult at rest is about 4 to 8 liters per minute. And without that output, tissue just dies.
And the left ventricle, I mean, it's massively thick, right? 2 to 3 times thicker than the right?
Oh, yeah. It has to forcefully blast that blood all the way down to your toes and back up against immense systemic resistance. Every critically ill patient you will ever care for is at risk of that system just completely collapsing.
So to prevent that collapse, you have to manipulate the magic trio that makes up stroke volume. That's preload, afterload, and contractility.
Right.
The old textbook analogy for preload is a stretching rubber band, but let's look at what's actually happening at the cellular level. Preload is the volume of blood stretching the ventricular myocardium at the end of diastole, right before it squeezes.
Exactly. What you're doing is stretching the individual sarcomeres. Those are the contractile units of the muscle fibers. According to the Frank-Starling law, as that volume of blood stretches the fibers, the actin and myosin filaments overlap more optimally.
Which creates a much greater force of contraction.
Up to a point, though. If you overstretch a sarcomere, those filaments get pulled too far apart, they lose their grip on each other, the muscle gets flabby, it loses elasticity, and boom, you've got acute heart failure.
Wow. Okay, so that's preload. Then we have afterload, which is the resistance the heart has to overcome. I've heard it compared to, like, blowing through a tiny coffee stirrer. But a better way to think about it is trying to push open a heavy, rusted iron door in the middle of a hurricane.
I love that analogy. That windstorm is the systemic vascular resistance. If a patient's arteries are clamped down, maybe constricted by their sympathetic nervous system or by our vasopressor drips, the blood pressure is sky high.
Right.
So the left ventricle faces massive, crushing resistance, just trying to pop the aortic valve open to push blood out.
And if that rusted door stays heavy for months or years, the left ventricle has to bulk up just to open it, right? It hypertrophies.
Yes, but not in an athletic, efficient way. The oxygen demand of that thick, beefy muscle skyrockets. The actual chamber size shrinks, so it holds less blood. And eventually, the engine just seizes up.
Which brings us to the third piece, contractility. This is the raw, independent squeeze of the muscle fibers, regardless of how much they're stretched by preload or the resistance from afterload.
And the trigger for this entire mechanical process is electrical. The sinoatrial node, the pacemaker in the right atrium fires, that electrical impulse spreads, depolarizing the atria.
Which is what you see as the P wave on an ECG.
Exactly.
Yeah.
Then the signal hits the AV node, travels down the bundle of His, and shoots through the Purkinje fibers. That's your QRS complex. The ventricular depolarization, the absolute command to squeeze.
Following that squeeze, the cells have to reset. They repolarize, which gives us the T wave, and sometimes you'll see a U wave, right?
Yeah, late repolarization. It can be a subtle clue for hypokalemia or low potassium, but the vital physiologic safeguard here is the absolute refractory period.
What does that mean exactly?
It means during ventricular contraction, the heart muscle will not respond to any new electrical stimuli. It is a biological lockout mechanism. It prevents the heart from going into continuous chaotic spasms like tetanus in a skeletal muscle.
Okay, so that's the ideal state. But when we're actually at the bedside and this hemodynamic engine starts to sputter, what are the earliest clinical findings? Like before the alarms go off, what tells us the stroke volume is dropping?
You look at the pressure gradients.
Yeah.
An early classic sign of a failing engine is a narrowing pulse pressure.
Right.
Pulse pressure is simply the systolic blood pressure minus the diastolic pressure. In a healthy state, it should be about 1/3 of the systolic pressure. So if your patient is 120/80, the pulse pressure is 40.
But let's say a patient is actively bleeding out hypovolemia, or they've had a massive heart attack and the pump is failing. The body's immediate compensation is to clamp down on the blood vessels to keep pressure up, right? Which raises the diastolic number, while the failing pump can't push the systolic number up. So the gap narrows. They might be 100/80, a pulse pressure of just 20.
And that narrow pulse pressure is a blaring siren. That stroke volume is critically low. A later, and honestly far more dangerous finding, is when the mean arterial pressure, the MAP, drops below 60 millimeters of mercury.
And the MAP is the average pressure within the arterial system over the entire cardiac cycle. The calculation is systolic plus 2 times the diastolic, all divided by 3.
Right. We multiply the diastolic by 2 because the heart spends twice as much time resting and filling during diastole as it does squeezing during systole.
And that number 60, it's not arbitrary, is it?
Not at all. Autoregulation in the body's capillary beds requires a minimum pressure to push oxygenated blood into the tissues. A MAP strictly greater than 60 is required to perfuse vital organs.
So if you look at the monitor and see a MAP hovering at 55,
vital organs are actively starving. The kidneys are shutting down and stopping urine production. The gut is becoming ischemic, and the brain is losing perfusion, which you'll see as confusion or lethargy.
So if you walk into the room and recognize a falling MAP and a narrow pulse pressure, the immediate nursing problem is decreased cardiac output. And the measurable goal is keeping that MAP above 60. But wait, if they are hypotensive, my first instinct is to just blast them with IV fluids to fill the tank. Why wouldn't we just do that immediately?
Because you have to identify why the cardiac output is low before you intervene. If the tank is empty hypovolemia, then yes, fluid is the answer. You are optimizing preload.
But if it's the pump?
Exactly. If the heart is a failing dilated pump, overflowing the tank just backs fluid up into the lungs. You'll drown the patient in pulmonary edema. You must manipulate the specific part of the stroke volume trio that is actually failing.
This is where our vasoactive medications come into play. If preload is low, we give volume. If afterload is too high, we use vasodilators to open that rusted door. And if contractility is weak, if the pump itself is failing, we give positive inotropes.
Drugs like epinephrine, norepinephrine, dopamine, dobutamine, and milrinone. We use these positive inotropes to forcefully increase the strength of the myocardial contraction.
But there is a massive physiologic cost, isn't there?
A huge cost.
Oh, yeah.
You're artificially whipping a tired horse. It will run faster and pull harder, but it drastically increases myocardial oxygen demand. A heart that is already failing might just suffer a catastrophic ischemic event because you forced it to work harder than its oxygen supply could support.
Wow. And conversely, we have negative inotropes like beta blockers and calcium channel blockers. If we think about calcium channels, calcium is the literal trigger for the muscle fibers to slide together and contract. So if you block those channels, you decrease contractility. You give the heart a rest, which decreases its oxygen demand. But the tightrope walk is making sure you don't drop the cardiac output so low that the organs starve.
And all of this is orchestrated by the autonomic nervous system. The sympathetic nervous system, our fight or flight response, uses beta-adrenergic receptors to increase heart rate and contractility. It also triggers alpha-1 receptors in the blood vessels, causing intense vasoconstriction to bump up that afterload and maintain pressure.
While the parasympathetic system, running primarily through the vagus nerve, acts as the brakes, slowing the heart rate down.
Exactly. And we also have these incredible chemoreceptors sitting in the medulla. If they taste the blood and detect high carbon dioxide, acidosis, or a lack of oxygen, they instantly stimulate the vasomotor center to increase blood pressure, forcing more blood flow to the lungs and tissues to clear out the waste.
When a patient begins to deteriorate, when their stroke volume falls, the body's most immediate compensatory mechanism is to speed up the heart rate. Tachycardia is a classic early sign of a failing system.
Because CO equals HR times SV. If SV drops, HR must rise to compensate. But this creates a lethal paradox in the critically ill.
Let me guess. If the heart is pumping faster, it's doing more work, which means it needs more oxygen. But it's already failing.
It's actually worse than that. It comes down to the anatomy of the coronary arteries. The myocardium has its own blood supply, the left anterior descending, the circumflex, the right coronary artery. These vessels branch off the very base of the aorta. Here is the critical physiological quirk. Blood flow into these coronary arteries occurs almost entirely during diastole, when the heart muscle is relaxed.
Oh, wow. Because when the massive left ventricle squeezes during systole, the physical pressure of the muscle contraction literally squeezes its own blood vessels completely shut.
Exactly. It can only feed itself when it's resting.
That's wild.
So imagine a patient's heart rate shoots up to 180 beats per minute. The amount of time the heart spends in diastole becomes incredibly short. There is literally no time for the ventricles to fill with blood, meaning stroke volume plummets. But far more dangerous, there is no time for the coronary arteries to receive oxygenated blood. The heart starves itself. Severe cardiac ischemia follows rapidly.
That is a terrifying feedback loop. A high heart rate is absolutely not your friend in the ICU. So if we see a MAP hovering near 60, we are notifying the provider to adjust the drips. But if that MAP drops below 60 and the patient starts getting confused or lethargic, that's a rapid response.
Because the brain is actively losing perfusion. Let's lock in some pattern recognition here. If you feel a bounding, forceful pulse with a wide pulse pressure, say 1/60/60, what is the failing physiology?
That's a hyperkinetic state. Either they are exercising or it's a structural issue like severe atherosclerosis where the arteries are calcified pipes that just can't expand and recoil to absorb the pressure.
Spot on.
Yeah.
And if you feel a thready, weak pulse with a narrow pulse pressure like 90/75.
The stroke volume is tiny, the body is clamping down to survive. I'm immediately thinking severe heart failure or massive hypovolemia. So, bringing this engine concept together for our listeners, if you remember only 5 things from this section. Number 1, the core pathophysiology is that cardiac output relies on heart rate and the preload afterload contractility trio.
Number 2, the absolute priority assessment is ensuring the MAP remains greater than 60 to prevent vital organ ischemia.
Number 3, the most dangerous complication we are watching for is severe tachycardia because it steals diastolic filling time and starves the heart of oxygen.
Number 4, your priority action is to calculate and constantly trend the MAP and post pressure.
And number 5, the most important treatment is balancing that hemodynamic trio using fluids or inotropes based on the specific failure.
The one-sentence clinical picture here. If you see a tachycardic hypotensive patient with a narrow pulse pressure, you must recognize that they have exhausted their cardiac reserve. They are rapidly heading toward ischemic organ death, and you must intervene immediately.
Right, but realizing that the pulse pressure is narrowing is really only half the battle. If a patient is crashing, a blood pressure cuff cycling every 3 minutes on their arm just isn't going to cut it. By the time the cuff gives you a reading, the physiology has already completely changed.
You need to get inside the artery. We need continuous beat-to-beat pressure data to titrate life-saving vasoactive drips safely.
And this is where we transition from non-invasive assessments to the intensive care toolkit. We are utilizing arterial lines for real-time systemic blood pressure, central venous pressure, or CVP catheters to measure right-sided heart preload, and pulmonary artery catheters, the Swan-Ganz, to measure left-sided heart pressures.
And the physics of an arterial line are fascinating. You can't just put a catheter into the radial or femoral artery and hook it up to a bag of normal saline on an IV pole.
Because the arterial pressure is so high, it would just push a column of blood right back up the tubing and out of the patient, right?
It's exactly. To counteract that arterial force, we use a pressurized flush system. We place the saline in a pressure bag and inflate it to a strict 300 millimeters of mercury. This overcomes the patient's blood pressure and delivers a continuous microscopic flush of about 1 to 3 milliliters per hour.
Which keeps the catheter patent and prevents lethal clots from forming in the artery. But the technology is useless if it's not calibrated to the patient's actual body. You have to zero the system to atmospheric pressure, and more importantly, you have to level the transducer to the phlebostatic axis.
Yes.
I always think of this like calibrating a submarine's depth gauge. If the gauge thinks it's at sea level when it's actually 100 feet down, the pressure readings will be entirely wrong. So where exactly is this axis?
The phlebostatic axis is an external anatomical landmark that precisely corresponds to the level of the atria of the heart. To find it, the patient must be lying supine. You draw an imaginary horizontal line from the axilla midway between the anterior and posterior chest walls. Then you draw a vertical line straight down from the fourth intercostal space, where those two lines intersect on the side of the chest. That is your 0 point.
You literally take a pen and mark a dot on their chest. The stopcock of the transducer must be mounted or teeped exactly level with that dot.
And this is where a subtle but deadly clinical mistake happens. Gravity exerts a profound effect on the fluid column in that tubing. If the transducer falls off the bed onto the floor or is secured lower than the phlebostatic axis, the weight of the fluid pushes down on the sensor. It will produce falsely high blood pressure readings.
Oh, wow. And conversely, if the transducer is placed higher than the axis, gravity pulls the fluid away from the sensor, producing falsely low readings.
Exactly. So if a patient's arterial line suddenly reads 50/30 and the alarm is screaming, your first action shouldn't be to blindly push a bolus of epinephrine. Your first action is to look at the patient and look at the physical setup. Did they slide down in bed? Did the transducer drop?
Treat the patient, not the monitor. You also have to verify that the system is dynamically responding to pressure changes without distortion. We perform a square wave test.
Right. When you pull the fast flush pigtail, the monitor should show a sharp vertical upstroke, a flat top, and then a rapid downstroke with 1 or 2 small, crisp oscillations, the ringing, before returning to the normal arterial waveform.
And if the wave is slurred, overdamped, or underdamped, there might be a clot, an air bubble, or kinked tubing. Your numbers are lying to you.
Before you even assist a provider with inserting a radial arterial line, though, there is a non-negotiable assessment that has to happen, the Allen test. Because if you put a catheter into the radial artery, there is a real risk it could occlude the vessel. We have to guarantee that the hand will still survive.
We are assessing the collateral circulation. The hand is supplied by a loop connecting the radial and ulnar arteries. So you instruct the patient to make a tight fist to force blood out of the hand, while you manually compress both the radial and ulnar arteries at the wrist.
Right, and the hand will turn completely pale and blanched.
Then the patient relaxes their hand, and you release the pressure on the ulnar artery only. You keep the radial artery compressed.
You are testing to see if the ulnar artery alone can perfuse the entire hand. Pinkness must return to the palm and fingers in less than 6 seconds. If it remains pale, the ulnar circulation is inadequate.
And the priority action is absolutely clear. Do not use that radial artery. If you insert a line there and it thromboses, the patient will suffer gangrene and lose their hand.
Once that line is in, monitoring neurovascular status distal to the insertion site hourly is critical. Capillary refill, color, temperature, motor function. If that limb becomes cool, pale, and pulseless, you are calling for immediate intervention to save the limb.
The other nightmare scenario is a disconnected line.
Because it's under arterial pressure, a disconnected line will cause rapid catastrophic hemorrhage. The monitor's low-pressure alarm will sound instantly. Your immediate action is to clamp the line, apply firm manual pressure directly over the site, and call for help.
So the arterial line gives us the systemic pressure. But what if we need to know what's happening inside the heart itself? This brings us to the pulmonary artery catheter, the Swan-Ganz. I was reading the historical development and the mechanics of this, and the procedure is genuinely terrifying.
It really is when you think about it.
We take a multi-lumen catheter, inflate a tiny balloon at the tip, and let the venous blood current physically sweep it into the right atrium, down through the tricuspid valve into the beating right ventricle, and then blast it up into the pulmonary artery.
It is highly invasive, and the risk profile is massive. But the data it provides is unparalleled for a patient in complex mixed shock. The bedside nurse's role is to monitor the pressure waveforms meticulously as that catheter flutes through the chambers, because the waveforms tell you exactly where the tip is located.
So the catheter enters the right atrium first. The waveform on the monitor is a small, blunt, rolling wave with low pressure, usually less than 10 millimeters of mercury. This is our CVP, the central venous pressure. It tells us the right-sided preload.
But as the catheter crosses the tricuspid valve and drops into the right ventricle, the waveform violently changes. You see tall, sharp, dramatic spikes. The systolic pressure jumps to around 25, while the diastolic drops near 0. This is the danger zone.
Why is it so dangerous?
Because you have a foreign plastic tube bouncing against the highly irritable endocardial wall of the right ventricle. It can easily trigger premature ventricular contractions or send the patient straight into ventricular tachycardia right in front of you. Continuous ECG monitoring and having a defibrillator in the room are absolute requirements during insertion.
Wow. Then the blood flow sweeps it up through the pulmonic valve into the pulmonary artery. The waveform smooths out slightly. It looks a bit like an arterial line tracing. The systolic is still around 25, but the diastolic pressure rises to about 10. And finally, the balloon is carried into a smaller distal branch of the pulmonary artery until it physically wedges into the vessel, blocking blood flow from behind it.
That is the pulmonary artery wedge pressure. Because the inflated balloon blocks the pressure coming from the right ventricle, the sensor at the tip is looking through a static column of blood through the pulmonary capillary bed directly into the left atrium.
And normal wedge pressure is 6 to 12 millimeters of mercury.
Right. It is our most accurate reflection of left ventricular preload and left-sided heart function.
It's an incredible piece of physics. We use the right side of the heart as a window to measure the left side of the heart. So if we see a patient with a high CVP, say 18, and they have distended neck veins and swollen edematous legs, what is the failing physiology?
The right ventricle is failing to pump blood forward into the lungs. So the blood backs up into the right atrium and then spills backward into the systemic venous system, engorging the jugular veins and pooling in the lower extremities. That is right-sided heart failure.
But if we see a patient with a high wedge pressure, say 22, and they are acutely short of breath with fluid in their lungs.
Now the left ventricle is failing. It can't pump blood out to the body, so pressure builds in the left atrium, which backs up directly into the pulmonary veins and capillaries, forcing fluid into the alveoli. That is left-sided heart failure.
We've been talking a lot about filling the tank, about preload. There's newer, less invasive technology mentioned in the text that helps us determine if a patient actually needs fluids, rather than just guessing based on CVP, APCO, or arterial pressure-based cardiac output.
It is a massive leap forward. Instead of floating a Swan-Ganz, APCO uses a specialized sensor attached to a standard arterial line. It analyzes the contour and area of the arterial pulse wave to continuously calculate stroke volume. But its most powerful feature is calculating stroke volume variation, or SVV.
How does SVV tell us if they need fluids?
It relies on the interaction between the heart and the lungs during mechanical ventilation. When a ventilator pushes a breath into the lungs, it increases intrathoracic pressure, which briefly squeezes the vena cava and decreases venous return to the heart.
Okay, that makes sense.
If a patient's tank is relatively empty, if they are hypovolemic, that positive pressure breath will cause a massive drop in their stroke volume for that single beat. The monitor calculates the percentage of variation beat to beat.
So a high stroke volume variation means the patient's cardiac output is wildly swinging with every breath they take, which means they are highly responsive to preload. If you give them a fluid bolus, their cardiac output will definitively improve. It takes the guesswork out of fluid resuscitation.
Exactly. It's brilliant.
So consolidating the invasive monitoring profile for you, 5 things to remember. Number 1, the core pathophysiology is that wedge pressure measures left-sided preload, while CVP measures right-sided preload.
Number 2, the key assessment is rigorous, hourly neurovascular checks on any limb with an arterial line.
Number 3, the most dangerous complications are arterial hemorrhage from a disconnected line or limb ischemia from a thrombus.
Number 4, the absolute priority action before believing any number on the screen is ensuring the transducer is leveled exactly to the phlebostatic axis at the 4th intercostal space, mid-axillary line.
And number 5, the most important treatment is maintaining that pressure bag at 300 mmHg for a continuous flush.
So if you see an absent ulnar pulse during an Allen test, think inadequate collateral circulation and do not insert a radial arterial line in that arm.
We've built the engine and we've wired it up to the monitors. But what does this look like in a human being? Technology fails, transducers drop, lines clot. A masterful critical care clinician must be able to read the physical body. We are going to explore this bedside assessment through a case study from the text, the case of LP.
LP is a 63-year-old male. He was brought to the emergency department by ambulance at 0600. His presenting symptoms were chest tightness, severe shortness of breath, and palpitations. He was convinced he was having a massive heart attack.
The paramedics followed protocol. They gave him oxygen, aspirin to prevent further clotting, and a sublingual nitroglycerin tablet to vasodilate his coronary arteries. By the time he rolls through our doors, his chest tightness has resolved, but he is still complaining of intense palpitations. His blood pressure is soft, 100/54. His apical pulse is racing at 154 beats per minute, and it is highly irregular. His lungs are clear to auscultation, and he has no jugular venous distension.
Why does his age, 63, matter in this context? Because aging fundamentally alters the physiological baseline of the cardiovascular system. As we age, the myocardial muscle loses elastin and replaces it with tough collagen. The heart becomes stiffer, less compliant, doesn't stretch and fill as easily during diastole.
The valves take a beating too, right? Decades of mechanical stress lead to lipid accumulation and calcification, especially on the aortic and mitral valves on the high-pressure left side of the heart. The doorways get thick and rigid.
They do. And this creates an interesting diagnostic nuance. If you auscultate an older adult's chest and hear a systolic murmur, does that definitively mean they are in overt heart failure? Not necessarily. Valvular rigidity from age-related calcification causes turbulent blood flow, which generates the murmur sound without necessarily indicating severe, decompensated cardiovascular disease. It is a sign of wear and tear.
But the electrical system degrades as well. The number of active pacemaker cells in the SA node decreases dramatically with age. The cellular dropout makes older adults highly susceptible to sinus dysrhythmias, ectopic beats, and varying degrees of heart block. Their autonomic nervous system also loses its sharp edge. The baroreceptors, the stretch and pressure sensors in the carotid arteries and aortic arch become blunted and less sensitive.
Which is why orthostatic hypotension is such a massive risk in this population. When a young person stands up, gravity pulls blood into their legs. The baroreceptors instantly sense the pressure drop and fire off a sympathetic response, constricting the blood vessels to shoot blood back to the brain. In an older adult, that reflex is delayed. The blood pools, the brain loses perfusion, and they become dizzy or suffer a syncopal fall. A drop of more than 20 millimeters of mercury in systolic pressure upon standing is a severe red flag.
Let's bring this back to LP. His apical pulse is 154 and irregular. We place him on the continuous ECG monitor, and it reveals atrial fibrillation with a rapid ventricular response, AFib-RVR. The atria are not squeezing cooperatively, they are just quivering, firing chaotic electrical signals down to the ventricles.
The failing physiology here is twofold. First, because the atria are just quivering, LP has lost his atrial kick, the coordinated squeeze that provides the final 20 to 30% of blood volume into the ventricles before they contract. Second, at 154 beats per minute, his diastolic filling time is severely compressed. His stroke volume is plummeting.
We have to control that heart rate and stabilize his hemodynamics. The immediate clinical priority is rate control, likely with IV calcium channel blockers like diltiazem or beta blockers. But here is where bedside judgment overrides algorithms. The paramedics gave him nitroglycerin for his chest pain. Nitroglycerin is a potent venous and arterial vasodilator. It massively drops preload and afterload.
And right now, LP's blood pressure is 100/54. If you follow a generic chest pain protocol and administer more nitroglycerin while he is in AFib-RVR, you will obliterate what little venous return he has left. His blood pressure will bottom out, his MAP will crash below 60, and he will code. You must address the immediate threat, the chaotic, rapid heart rate, before you do anything else.
How do we physically assess the severity of this dysrhythmia without just looking at the monitor? We assess for a pulse deficit. This is a classic high-yield finding in atrial fibrillation.
A pulse deficit occurs when the electrical activity of the heart is so rapid and chaotic that some of the mechanical contractions simply do not have enough stroke volume to open the aortic valve and push a palpable pulse wave all the way down to the wrist. To assess this, you need two clinicians. One auscultates the apical pulse at the chest with a stethoscope, while the other simultaneously palpates the radial pulse. You count for 1 full minute.
If you are listening to LP's chest and you count 154 beats, but the nurse at his wrist only feels 110 beats, you have a pulse deficit of 44. The monitor might say 154, but mechanically only 110 of those beats are actually perfusing the body. The engine is spinning its wheels.
Beyond the pulse deficit, we need to look for early and late signs of cardiovascular collapse. We talked about JVD for right-sided failure. You position the patient upright at 30 to 45 degrees. If the jugular veins are bulging and distended, the right atrial pressure is severely elevated.
You also want to palpate the PMI, the point of maximal impulse. In a normal heart, the apex taps against the chest wall at the 5th intercostal space, right at the midclavicular line. But if the left ventricle has spent years pushing against high afterload and has become enlarged and hypertrophied, that point of impulse gets physically displaced downward and laterally to the left.
What about the subtle, late-stage, dangerous signs? Look at the patient's mouth. Central cyanosis, a bluish tinge in the tongue, the oral mucosa, or the lips, indicates that the arterial blood oxygenation is fundamentally inadequate. It is a much more ominous sign than peripheral cyanosis in the fingers, which can just be from a cold room.
Another fascinating and terrifying subtle sign: splinter hemorrhages. If you look at a patient's fingernails and see tiny vertical red or black streaks under the nail bed, it looks like a wood splinter. But it's actually microemboli. It is a classic hallmark of infective endocarditis. Bacteria are actively destroying the heart valves, and tiny clumps of vegetation are breaking off and lodging in the capillary beds of the fingers.
Auscultation is an art form that takes years to master. We use the anatomic landmarks: aortic, pulmonic, Erb's point, tricuspid, and mitral. S1, the lub, is the sound of the tricuspid and mitral valves slamming shut at the beginning of systole. S2, the dub, is the aortic and pulmonic valves closing at the start of diastole.
Those are the normal high-pitched sounds, but when the physiology is failing, you hear the extra heart sounds, the gallops, S3 and S4. These are low-pitched sounds, so you have to use the bell of the stethoscope, pressing lightly against the skin at the apex. An S3 gallop happens immediately after S2. It sounds like lub-dub-ta.
And S3 is the sound of blood violently splashing into an already overfilled, non-compliant left ventricle during early diastole. In a healthy young athlete, an S3 can be a normal finding, but in an older adult like LP, it's highly pathologic. It screams volume overload, indicating acute left-sided heart failure.
The S4 gallop happens right before S1. To lub-dub. This is the sound of the atria forcefully contracting and smashing blood against a stiff, resistant, hypertrophied ventricle. You hear it a lot in patients with chronic, uncontrolled hypertension.
You might also hear a pericardial friction rub. It is a harsh, high-pitched, scratchy sound, exactly like rubbing two pieces of rough sandpaper together. It occurs when the pericardial sac surrounding the heart becomes inflamed, and the layers rub against each other with every beat. To hear it clearly, have the patient sit upright, lean forward, and hold their breath at the end of expiration. This maneuver pushes the lungs out of the way and brings the heart right up against the chest wall. Moving down to the extremities, you are assessing for edema, grading it from a mild 1+ pitting to a severe deep 4+ pitting, and you are checking bilateral pulses for symmetry. But this brings up a massive, potentially lethal clinical pitfall regarding the carotid arteries. It is an absolute rule of physical assessment: never palpate both carotid arteries at the same time.
It seems counterintuitive, right? With radial or pedal pulses, we always palpate them simultaneously to compare the strength on the left versus the right. Why not the carotids?
Because the carotid sinus contains a dense cluster of those baroreceptors we talked about. If you press on both carotid arteries simultaneously, the brain interprets that massive pressure spike as life-threatening hypertension. It instantly triggers the vagus nerve, causing a maximum parasympathetic response. The patient's heart rate will crash into severe bradycardia or even a systole, and they will suffer a vagal syncope right into your arms. Always assess them one side at a time.
Let's talk about tissue perfusion and the different types of ulcers you see in cardiovascular patients, because the interventions are entirely opposite depending on the pathology. If you assess a patient's foot and you see a pale, deep, ischemic ulcer with sharply defined, punched-out edges, usually on the tips of the toes or the heel, what is failing?
That is severe peripheral arterial disease. Oxygenated blood simply cannot get down the pipes to the tissue. The tissue is starving and dying.
But if you look at the medial malleolus, the inside of the ankle, and you see a superficial, necrotic, crater-like ulcer that is weeping fluid with thick, brown, leathery skin surrounding it,
that is venous disease. The arterial blood gets down there just fine, but the venous valves are destroyed. The blood cannot get back up to the heart. It pools in the lower leg, the pressure builds, and the stagnant fluid physically destroys the tissue from the inside out.
So we have LP on the monitor and AFib RVR. How do we know he is deteriorating before the alarms sound?
You watch for the tipping point where his rapid heart rate finally overwhelms his cardiac reserve. If his palpitations progress to syncope, his cardiac output has dropped so low his brain is starving. Or if his lungs, which were cleared 20 minutes ago, suddenly sound full of wet crackles and you auscultate a new S3 gallop. That means his left ventricle has failed, and fluid is rapidly backing up into his alveoli.
If he develops new-onset crushing chest pain and his pulse deficit widens significantly, meaning even fewer beats are perfusing, you are calling a rapid response. The AFib is starving his coronary arteries, and he is actively having an ischemic event.
To synthesize the bedside assessment, remember these 5 things. 1. The core pathophysiology of aging includes the loss of elastin, arterial stiffening, and a dangerous drop in SA node pacemaker cells.
2. A critical assessment finding is the pulse deficit, strongly indicating dysrhythmias like atrial fibrillation, where the mechanical pump cannot keep up with the electrical chaos.
3. The most dangerous complication of assessment is causing a vagal crash by simultaneously palpating both carotid arteries.
4. Your priority action when a patient presents with a rapid, irregular rhythm is to assess their hemodynamics. First is the MAP above 60, and then obtain a 12-lead ECG to identify the specific electrical failure.
And 5. The most important treatment is ensuring patient safety against orthostatic and postprandial hypotension in the elderly.
If you see the PMI displaced left of the midclavicular line and below the 5th intercostal space, think left ventricular enlargement and do auscultate for an S3 gallop.
Which brings us to the ultimate crisis. What happens when the coronary arteries finally occlude? When the heart muscle is actively dying? We move into the diagnostics of acute coronary syndrome, biomarkers, and the cath lab.
When we are dealing with a myocardial infarction, the universal mantra is time is muscle. Rapid interpretation of cardiac biomarkers dictates the entire trajectory of the patient's life. Do they stay in the ICU for medical management, or do we rush them down the hall to the cardiac catheterization lab to physically rip open a blocked artery?
The cellular pathophysiology of an MI is brutal. A coronary artery is suddenly blocked by a ruptured cholesterol plaque or a thrombus. The myocardial tissue downstream is instantly starved of oxygen. As those muscle cells become ischemic, their internal engines shut down. The cell membranes lose their integrity and literally burst open. When they rupture, they spill their unique intracellular proteins directly into the bloodstream.
And we can draw blood and measure those specific proteins, these biomarkers, to definitively prove that heart muscle is dying. The absolute, undisputed gold standard for diagnosing an MI is troponin.
Specifically, cardiac-specific troponin T and troponin I. These structural proteins are highly specific to myocardial tissue. In a healthy person, circulating troponin levels are essentially 0. If you draw a lab and the troponin is elevated, the heart is taking active damage.
The kinetics of how fast these markers appear is crucial for triage. Standard troponin assays will show a rise within 4 to 6 hours of the initial ischemic injury. They peak between 10 and 24 hours, and they can remain detectable in the blood for up to 2 weeks. But technology has advanced. We now use high-sensitivity troponin assays that can detect microscopic cellular damage much earlier, often within 1 to 3 hours of symptom onset.
We also look at copeptin. It's a surrogate marker for arginine vasopressin, which shoots up during the massive physiological stress of an acute MI. If you test both high-sensitivity troponin and copeptin together in the ED, it provides an incredibly rapid, highly accurate ruling in or ruling out of an MI. And notably, high levels of copeptin strongly correlate with increased mortality.
You might still see CKMB mentioned in older protocols. Creatine kinase is an enzyme, and the MB isoenzyme is specific to the heart. It rises in 3 to 6 hours and normalizes very quickly, usually within 48 hours. It used to be the gold standard, but frankly, troponin is so vastly superior in both sensitivity and specificity that CKMB is rarely the primary driver of clinical decisions today.
Biomarkers aren't just for heart attacks. Imagine a patient is rushed into the ICU, gasping for air, profoundly dyspneic. You don't have time for a full history, and you need to know instantly. Is this a severe COPD exacerbation, or is their heart failing and filling their lungs with fluid?
You draw a BNP B-type natriuretic peptide. The physiology behind this is fascinating. This peptide is synthesized and stored specifically in the ventricles of the heart. When the ventricles are excessively stretched by volume overload, like in acute heart failure, they release massive amounts of BNP into the blood to tell the kidneys to excrete sodium and water.
It is a brilliant diagnostic separator. If dyspneic patient's BNP is normal, the stretch on the heart is normal, the breathing problem is almost certainly pulmonary. If the BNP is sky high, the ventricles are screaming for relief. It's a cardiac issue.
Before we send someone to the cath lab, we often use imaging. Echocardiograms use ultrasound to visualize the physical structure of the heart, the valves, and calculate the ejection fraction. But doing an echo through the chest wall is tough. The ribs, lung tissue, and body habitus get in the way of the sound waves.
When we need perfect clarity, we use a T, a transesophageal echocardiogram. The esophagus sits in the chest cavity immediately posterior to the heart. There is no bone or air to block the signal. We pass a flexible endoscope equipped with an ultrasound transducer directly down the patient's throat into the esophagus. It gives us stunning high-definition images of the atria and the valves. It is the absolute best way to hunt for tiny clumps of bacteria from endocarditis or blood clots hiding in the left atrial appendage.
But there is a massive nursing hazard attached to this procedure. The patient must be strictly NPO nothing by mouth for at least 6 hours prior to the T to prevent them from vomiting and aspirating stomach contents when the scope goes down. During the procedure, the provider sprays a potent local anesthetic into the back of the patient's throat so they don't gag on the scope.
And here's the trap that catches novice nurses. Post-procedure, the patient is going to complain that their throat is incredibly dry and they are dying for a sip of water. If you hand them a cup of water, the back of their throat is still numb. The epiglottis won't close. They will aspirate that water straight into their trachea and lungs. You must keep them strictly NPO until you physically take a tongue depressor and verify that their gag reflex has fully returned.
Okay, let's talk about the ultimate interventional tool, cardiac catheterization or coronary angiography. This is where we definitively prove the plumbing is blocked and we fix it.
It requires accessing the high-pressure arterial system, usually via the femoral artery in the groin or the radial artery in the wrist. We thread a long, thin catheter retrograde against the flow of blood all the way up the aorta until we hook the tip right into the origin of the coronary arteries. Then, we inject a radiopaque contrast dye while taking continuous real-time X-ray movies called fluoroscopy.
It is literally like sending a tiny plumber's snake camera into the pipes. The contrast dye fills the coronary arteries, showing up as dark, branching rivers on the X-ray screen. If there is a sudden narrowing or if the river just abruptly stops, that is our clot. That is the exact location of the MI.
And the brilliance of the cath lab is that it is both diagnostic and therapeutic. We don't just look at the clot. We can slide a microscopic wire right through the blockage, track a deflated balloon over the wire, and inflate it to a massive pressure, physically crushing the cholesterol plaque against the artery wall. Then we deploy a metal mesh stent to act as scaffolding, holding the vessel open permanently. Blood flow is instantly restored. The dying muscle is saved.
We can do a similar procedure for the electrical system called an electrophysiology study, or EPS. Instead of injecting dye to look at pipes, we insert catheters with tiny electrodes on the tips to map the electrical pathways from the inside of the heart. We can purposely induce dangerous dysrhythmias to pinpoint exactly which cluster of rogue cells is causing the problem, and then use radio frequency energy to ablate or burn that specific microscopic pathway, curing the dysrhythmia entirely.
But the bedside care of a post-cath patient is incredibly high stakes. You are managing an intentional puncture wound in a major high-pressure artery. Before the procedure even begins, you must assess for severe allergies to the iodine-based contrast dye. A warm, flushed feeling during injection is normal. Hives or anaphylaxis are not. You also absolutely must establish a baseline neurovascular assessment of the limb we are going to use. You need to know exactly how strong their pedal pulses are before we put a catheter in that leg.
The primary post-procedure diagnosis is a high risk for arterial hemorrhage at the puncture site and a high risk for contrast-induced nephropathy because that dye is incredibly toxic to the kidneys.
The implementation is strict. If a femoral approach was used, the patient must maintain absolute flat bed rest for hours to allow the artery to seal. You cannot let them sit up or bend their knee. You are observing the insertion site every 15 minutes for the first hour. And you are aggressively encouraging IV and oral fluids to flush that nephrotoxic dye out of the renal tubules as fast as possible.
What does a catastrophic complication look like here? How do we know the artery didn't seal?
You might see frank, bright red blood soaking through the dressing. But the more insidious danger is a hematoma or a retroperitoneal bleed. If the artery is leaking under the skin, you will feel a hard, expanding lump forming under the puncture site. If the blood tracks backward into the retroperitoneal space in the abdomen, you won't see a lump at all. The patient will simply start complaining of severe, deep back or flank pain, and their blood pressure will begin to crash as they quietly bleed out internally.
If you feel that expanding hard hematoma or you suspect a bleed, your immediate split-second action is to apply intense, firm manual pressure slightly above the puncture site to occlude the artery. You do not leave the patient. You hit the call bell and scream for help.
You also have to monitor for stent thrombosis. The patient is getting worse if they suddenly report a return of their original crushing chest pain. That means the stent we just placed has abruptly clotted off. The artery is occluded again. You need an immediate 12-lead ECG, and you must activate the cath lab team instantly.
Before we wrap up, there's one more diagnostic tool, the stress test. If a patient is stable but having exertional chest pain, we put them on a treadmill and monitor their ECG while they run. But what if the patient is a double amputee or has severe osteoarthritis and physically cannot walk?
We perform a pharmacologic stress test. We use intravenous medications to chemically simulate the physiological demands of exercise on the heart. If we want to artificially increase the heart rate and contractility to see if the heart can handle the workload, we infuse dobutamine. If we want to evaluate the plumbing by massively vasodilating the healthy arteries to see which ones are diseased and can't dilate, we use drugs like dipyridamole, rigaudinosin, or adenosine.
A vital pharmacology note. If a patient reacts poorly to dipyridamole and develops severe dyspnea or nausea, aminophylline is the specific reversal agent you need to have ready.
And here is a trap that routinely ruins exercise stress tests. If a patient is scheduled for a treadmill test and they take a daily beta blocker, you typically must hold that beta blocker for 24 hours prior to the test, verifying the order with the provider. Why? Because beta blockers put a chemical cap on the heart rate. The patient will exhaust their leg muscles on the treadmill and quit long before their heart rate ever reaches the target diagnostic threshold. The test will be completely useless.
So summarizing the diagnostics and cath lab physiology. 1. The core pathophysiology is that ischemic myocardial cells rupture, leaking cardiac-specific biomarkers like troponin into the blood. A rise in troponin is the definitive signal of myocardial death.
2. The absolute priority assessment is post-cath neurovascular checks and bleeding site checks every 15 minutes.
3. The most dangerous complication is a massive retroperitoneal bleed from a femoral artery access site.
4. The priority nursing action post-T is strictly enforcing NPO status until you physically verify the return of the gag reflex.
And 5. The most important treatment is rapid identification of rising troponins to expedite cath lab interventions.
If you see a patient scheduled for an exercise stress test who is on beta blockers, think blunted heart rate response and do hold the beta blockers for 24 hours prior if ordered.
We have covered immense ground today. We started with the microscopic overlap of sarcomeres dictating preload, moved through the chaotic electrical storms of atrial fibrillation, and ended with the intense mechanical interventions of the cath lab. We've ruthlessly applied the 80-20 rule to focus on what actually kills patients and how to stop it.
Looking back at the massive stack of texts we analyzed, there's a fascinating philosophical shift happening in the background of critical care. For decades, the gold standard for understanding a patient's hemodynamics was highly invasive. We relied on the Swan-Ganz catheter, accepting the terrifying risks of floating a balloon through a beating right ventricle to get the data we needed.
But now the texts are highlighting these advanced non-invasive technologies: arterial pressure-based cardiac output, thoracic bioreactance, finger cuff pulse wave analysis. We are extracting the exact same data: stroke volume, cardiac output, fluid responsiveness, using complex digital algorithms analyzing the contour of a peripheral pulse.
These non-invasive methods are proving incredibly reliable, and they completely eliminate the risk of central line-associated bloodstream infections, massive arterial hemorrhage, and fatal catheter-induced dysrhythmias. We are standing on the edge of a true paradigm shift. It begs the question, will the classic multi-lumen pulmonary artery catheter soon become a complete relic of the past?
It's incredible to think about. If the data is entirely outsourced to a non-invasive computer algorithm, how does that change the tactile, hands-on art of critical care nursing? Suddenly, those diagnostic muddy waters we talked about at the beginning get a whole lot clearer, and we don't have to risk the patient's life by putting a tube directly into their heart to see it. It is something profound to ponder on your next shift. Thanks for joining this intense critical care deep dive. Keep questioning the physiology, keep anticipating the deterioration, and we'll see you next time.